Dear student, my name is Dr. Ahmed Al-Mshari. I'm otolaryngology and neck surgery lecturer in Atlanta University. Today, I will present to you deep neck space infections, which might be called pharyngeal separations. In order to understand the deep neck space infection, you have to understand the anatomy of the cervical fascia. So basically, the cervical fascia is divided into superficial cervical fascia and the deep cervical fascia. And then the deep cervical fascia is divided into superficial layer, which is the investing fascia, investing sternocleidomastoid muscle and the trapezius muscle, while the middle layer invests the strap muscles and the trachea and esophagus, making the visceral fascia, while the deep layer of the deep cervical fascia closing the prevertebral muscles and forming the prevertebral fascia. All the three different layers are condensed in order to form carotid sheath, which encloses the carotid arteries and anterojugular vein, vagus nerve, and sympathetic chain. So the five main types of deep neck space infections, they are peritonsillar abscess or quinsy, parapharyngeal abscess, retropharyngeal abscess, and prevertebral abscess, and Ludwig's angina. So first of all is a peritonsillar abscess or quinsy. So the definition, it is a collection of pus in the peritonsillar space between the tonsillar capsule and the superior constrictor muscle, as you could see here in this diagram. Normally, peritonsillar abscess complicates acute follicular tonsillitis when suppuration involves the crypts of the supratonsillar fossa, which are closely related to the tonsillar capsule, which might spreading to the tonsillar fossa. The main cause of organism for the peritonsillar abscess are group A hemolytic streptococci and ropes. The clinical picture of the peritonsillar abscess, normally there is a history of preceding acute tonsillitis, which is a common finding. General symptoms include fever, anorexia, headache, and malaise. Local symptoms include progressive sore throat, which usually starts on both sides and then becomes lateralized to one side, and then it becomes throbbing pain, and it might be referred to as ipsilateral ear. The second symptom is dysphagia and odynophagia, and this causes accumulation of saliva, withdrawing, which is a characteristic symptoms, trismus due to reflex spasm of pterygoid muscles, hot potato voice due to oropharyngeal swelling and painful mobility of the palate. The signs, there is general signs as proportional fever with tachycardia and irritability. Local signs are unilateral swelling of the soft palate above and lateral to the tonsil, with medial displacement and limited mobility of the uvula, and downward and medial displacement of the tonsil. Limited mouth opening is a virtually pathognomonic. Enlarged tender jugular digastric lymph node is common. There are two main investigations in peritonsillar abscess. First of them is transoral needle aspiration of the pus, which is often diagnostic and therapeutic as well. It also helps to differentiate between peritonsillar cellulitis and peritonsillar abscess. It provides bacteriological specimen in recurrent and non-responsive quinsys. CT scan of the neck is indicated in suspected complication, and also it's very important in suspected spread to the parapharyngeal and retropharyngeal spaces. Differential diagnosis includes tumors of the tonsil and aneurysms of the internal carotid artery, which might bring blood on aspiration. Complication, there are three main complications. Rupture of the abscess will lead to inhalation pneumonia. Spread of the infection will lead to parapharyngeal abscess. Spread to the mediastinum will result in mediastinitis. Treatment is either medical treatment or surgical treatment. So medical treatment in peritonsillar cellulitis, before pus formation, there is parenteral antibiotic, hydration, and analgesics. Surgical treatment in peritonsillar abscess after pus formation, it's drainage of the abscess under local or general anesthesia by needle aspiration or incision drainage with quinsy knife. The incision is done at either the most pointing point, which is the best site for incision, or 2 or half centimeter lateral to the point, to the crossing point between horizontal line at the base of the uvula with the vertical line at the end anterior tonsillar pillar. Second line of surgical management is tonsillectomy, which is usually preferred after 1 month to prevent abscess recurrence. Second, deep neck space infection is parapharyngeal abscess. Its definition, it is a collection of the pus in the parapharyngeal space. So basically, parapharyngeal space is inverted pyramidal space. So the base of the pyramid is the skull base, and the tip of the pyramid is the hyoid bone. And there is several medial and lateral relationships with different structure in the neck. Etiology, the main etiology or the main cause for parapharyngeal space infection is dental infection. It's either extending to the parapharyngeal space from the masticator space or from the submandibular space. The other cause of etiology for parapharyngeal abscess is acute tonsillitis or quinsy, especially recurrent ones. Foreign body ingestion as fish bone might be penetrating to the pharyngeal wall and crossing to the parapharyngeal space, causing parapharyngeal abscess, penetrating neck trauma in intravenous drug users. Main causative organisms for parapharyngeal space infection is usually mixed infection by aerobic, microaerophilic, and anaerobic microorganisms. Parapharyngeal space infections, a serious infection which normally happen in predisposed patient with diabetes mellitus, HIV infection, hematological malignancies, and recent chemotherapy or corticosteroid therapy. Clinical picture of the parapharyngeal abscess includes general manifestation as fever, anorexia, malaise, and severe pain. Local manifestation as Beck's triad, as external red tender swelling in the lateral neck, especially at the angle of the mandible, internal swelling at the lateral pharyngeal wall, especially behind the posterior tonsillar pillar, teresmus and torticollis due to spasm of the medial tracheoid and sternocleidomastoid muscle. Investigation, CT scan of the neck with contrast is the standard method for evaluation of the extent of involved spaces. Plain X-ray of the jaw, panoramic view is required in parapharyngeal abscess of dental or unknown origins. Laboratory investigation, CBC, C-reactive protein, random blood sugar, and bleeding profile. Complication, rupture of the abscess internally will lead to inhalation pneumonia, externally will result in external fistula, spread to the mediastinum leading to mediastinitis, which is a fatal condition, internal jugular vein thrombosis, which is called Lemierre's syndrome. Carotid artery ruptures will lead to fatal hemorrhage, necrotizing cervical fasciitis. And treatment is, there are 3 different lines of treatment for parapharyngeal abscess. First one is airway management in impending airway obstruction with either awake fiber optic intubation or tracheostomy. Medical treatment as trial of conservative treatment for 48 hours before abscess formation or with surgical management. So all these serious cases should be hospitalized and should be given intravenous or parenteral antibiotics and should be adequately hydrated and should be given analgesics. Surgical management is indicated after pus formation or failure of conservative treatment after 48 hours with persistent fever, persistent or worsening pain. And normally, surgical management could be done with ultrasonic guided needle aspiration from small abscesses and transoral incision drainage for larger ones and pre-styloid ones, and transcervical incision drainage through cervical transverse incision in the submandibular region is the last resort for huge, large volume abscesses. Retropharyngeal and prevertebral abscess. So retropharyngeal is the one which is extending from the skull base down to the root of the neck, and the prevertebral abscess extending from the skull base down to the diaphragm level. So retropharyngeal abscess is a collection of pus in the retropharyngeal space. It normally happens due to suppuration and infection of the retropharyngeal lymph node, which is also called glands of Henle, which present on each side of the medial raphe. Source of infection is usually from adenoiditis, tonsillitis, or otitis media. Incidence, classically retropharyngeal abscess is the disease of infancy and early childhood because glands of Henle usually regress after the age of 5 years. Clinical picture symptoms usually occurs with a preceding or concurrent acute upper respiratory tract infection, sore throat which might be referred to the ear, painful dysphagia and difficulty in suckling, torticollis, obstructive symptoms as snoring, noisy breathing, nasal obstruction, and mouth breathing, irritative cough due to laryngeal irritation. General symptoms are fever, irritability, And local signs are swelling in the posterior pharyngeal wall, limited on one side, with a pus coming out on aspiration. Enlarged tender cervical lymph nodes. Differential diagnosis of retropharyngeal abscess is carotid aneurysm, which is normally pulsating swelling and brings blood on aspiration, while TB spine swelling is usually midline and not lateral. Complications of retropharyngeal abscess is laryngeal obstruction due to stridor and suffocation. Rupture of the abscess might lead to inhalation pneumonia, spread of infection to parapharyngeal abscess. Treatment is, first of all, is airway management in impending airway obstruction with either awake fiber optic intubation and tracheostomy. Medical treatment is a trial of conservative treatment for 48 hours before abscess formation or with surgical drainage. It consists of parenteral antibiotics, hydration, and analgesic. Surgical treatment only after pus formation with transoral needle aspiration, transoral incision drainage under general anesthesia with cuffed endotracheal tube. In such critical patients, the head should be kept down with suction of pus to avoid inhalation. Longitudinal incisions of posterior pharyngeal wall from below upwards, not traverse, to avoid any carotid injury for any retropharyngeal carotid arteries. Prevertebral abscess is a cold abscess or TB infection of the cervical vertebrae. It's also called Pott's disease, with extension of infection and accumulation of caseating material behind the prevertebral fascia. It usually occurs in adult complicating pulmonary tuberculosis. Symptoms, there is general symptoms as TB, toxemia, loss of weight, loss of appetite, night sweating, and night low-grade fever. Local symptoms include severe pain in throat and back of the neck, dysphagia and fetal chorus, cough and expectoration of blood sputum in open pulmonary TB. Signs, there is swelling in the posterior pharyngeal wall in the midline, and it is a fluctuant and cystic swelling with caseating material coming out on aspiration. There will be tenderness over cervical spine, which are kyphotic. Investigation, chest X-ray showing pulmonary TB, lateral neck X-ray showing destruction of vertebrae, widening of the prevertebral space or kyphosis, microbiological examination of the aspirate, TB bacilli, anti-tuberculous drugs as rifampicin, INH, isoniazid, pyrazinamide, and surgical incision drainage through cervical incision parallel to the posterior border of the systemic leukomastoid is the place and site of the incision in such deep neck infections. The last deep neck space infection is the Ludwig's angina. It is a separation bilateral sublingual, submandibular spaces and submental space as well. Most commonly this happens due to anterior dental infection, so infection in anterior teeth, rarely due to suppuration or suppurative salidinitis or lymphadenitis in the sublingual salivary gland or submandibular salivary gland or submandibular or submental lymph nodes. The clinical picture in such patient symptoms includes fever, malaise, voice changes, dyspnea, and severe neck pain. Signs, there is external swelling in the submandibular submental regions with signs of acute inflammation, cervical lymph node enlargement. Internal swelling, there is a gross edema of the floor of mouth and anterior tongue, leading to gross swelling and protrusion of the tongue. Also, there is a trismus in such cases. Complication, life-threatening airway obstruction, spread of infection leads to parapharyngeal abscess. Treatment, either there is airway management in impending airway obstruction, preferably with tracheostomy, as awake fiber optic intubation might be difficult in such a patient with the tongue pushed backwards. Medical treatment, again, as a trial of conservative treatment for 48 hours before abscess formation or with surgical drainage. A medical trial consists of parenteral antibiotics, hydration, and analgesics. Surgical management is indicated after pus formation or failure of 48 hours of conservative management with persistent fever, persistent or worsening pain, with ultrasonic guided needle aspiration. Transcervical incision and drainage through horizontal submental incision below and parallel to the body of the mandible. Thank you very much for your attention, and I wish you all best of luck.